Thanks for joining us tonight. My name is Ali Alikani. I'm from the University of Tennessee Health Science Center in Memphis, Tennessee. I'm the current RFS Advocacy Chair. We're here with the SIR Director of Government and Policy Affairs, Mr. Doug Huynh, who finally was able to figure out his microphone situation. Thank you, Doug, for joining us. Basically, this webinar is going to cover what SIRPAC is, basically the legislations that are affecting IR currently, kind of on a kind of a superficial explanation, not too deep, just to get everyone kind of familiarize themselves with SIRPAC, its efforts, what the basically goal and focus of SIRPAC is, what they advocate for, and why they do it, and where would the donations that are given to SIRPAC, basically where they're used and why they're useful. Before I go any further, I'm just going to go ahead and give the mic over to Doug. And Doug, did you want to go ahead and start and just let me know when you want me to switch over the slides?
Sure, I can do that. My apologies, everyone, for the technical glitch. There's something on my end, so again, I'm sorry about that.
No problem.
As Ali mentioned, I'm the Director of Government and Policy Affairs here at SIR. In that role, I basically act as a policy advisor for healthcare policy issues, and I advocate on behalf of IR before Congress. So in other words, I'm the SIR in-house lobbyist. We have other consultants that we use in the same capacity, but we primarily use them in an advisory role. So for the most part, the majority of the advocacy is done by myself and some of our members, volunteers, that sort of thing, that come to Capitol Hill from time to time. As Ali mentioned earlier, we put this webinar together to essentially educate you about SIRPAC and its role in advocacy, and in general, just to basically raise the awareness of both. At the end of the night, hopefully you'll come away with a general understanding of SIRPAC and advocacy at SIR. I'd like this session to be somewhat interactive. I don't think a lot of you are going to be able to speak via mic, so if you want to text your questions or replies, we can definitely get to those. So why don't we start with the first slide, Ali?
Yep. There's a bit of a lag with the. There you go.
Okay. So I've been at SIR for about 9 years now, and the one prevalent observation I've made is that many of our members don't know we have a PAC. For those that do know we have a PAC, a lot of them don't know what it does. One of the common misconceptions is that SIRPAC and advocacy are the same thing. While they both live under the same roof, they're essentially completely different entities which work together to complement each other. What they do have in common, however, is that they share the same goal, and that goal is to be the voice of IR on Capitol Hill. Next slide, please. So with that, let's start with the basics. Many of you probably know, but for those of you who don't, a PAC is essentially a political committee dedicated to raising and investing money to elect or defeat political candidates or to advance the outcome of a political issue or legislation. So that's the nuts and bolts of it. SIRPAC raises money for federal candidates only. So while other organizations might raise PAC money for state-based representatives, based on the size of SIR itself, we essentially just kind of concentrate on the federal candidates. 100% of your PAC money goes directly to the candidates, so none of it is used for any other means, including fly-ins, lunches with staff, that sort of thing. Two things that people probably don't know, one of which is none of the SIRPAC money comes from membership dues. And I know this is something that a lot of people get confused on in regards to, you pay a general membership fee. Some people presume that SIRPAC is covered within that fee, but everything that we do within the SIRPAC committee comes 100% from your donations that come outside of those membership dues. Another thing that people don't realize is that none of this comes from the ACR or the ACR PAC. Again, I do realize that a lot of SIR members are also ACR members, but as you'll soon see, once we talk about this later, we have completely distinct and separate issues, and in turn, our PACs are different. So we're on the next slide. How do we spend that money? SIRPAC distributes that money to federal candidates who are either pro-healthcare or pro-IR. or alternatively, someone that could help us with a particular issue, whether it be a healthcare issue or a budgetary issue. Again, that money goes towards current members of Congress, or it can go to a candidate that is seeking election as a freshman into Congress. So that kind of varies. We've had radiologists run in the past who wanted us to support them, which we've done. There hasn't been, so far as to date, a radiologist that has ever been a member of Congress. There actually have been a couple of IRs that have run for Congress, but never actually won that seat. When we contribute to members of Congress, we essentially look at a few criteria. The first of which is we try to either give to a member or candidate that's in one of these major committees of jurisdiction. So for those of you that are unfamiliar, essentially on the House side you have the Ways and Means Committee and the Energy and Commerce Committee, and on the Senate side you have the Senate Finance Committee or the Senate Health Committee. We also try to give to leaders on both sides of the aisle, on the House side or the Senate side, in both Republican and Democratic Party. Next slide, please. Why do we spend that money? That's a common question that we get asked not just from our leadership, but also from our general membership. The basic reason I can give you is that we spend the money to ensure that members of Congress who are favorable to our policy agenda stay in office, or alternatively, we spend that money to make sure that people that want to join Congress get elected. But to be perfectly candid, the primary reason that we contribute money through SIRPAC is to allow us access that we wouldn't otherwise have if we weren't contributing any of this money. The way that works essentially is that contributing to SIRPAC allows us to attend events that we wouldn't be allowed to attend, not so much attend, but it gives us access to people that we wouldn't otherwise have access to. As an example, a lot of times if you're going to Capitol Hill for a meeting, you'll usually speak with a health aide or sometimes even an intern. When you go to these actual PAC events, you get to speak to obviously the member of Congress themselves or the chief of staff, and of course the chief of staff or the staff director essentially runs the entire show. So if you want to get something done politically, if you want to get something done legislatively, you need to be able to speak to these key players in order to advocate your message properly. Giving money through the PAC does a lot of things. As I mentioned, it shows that we're key players, that we're taken seriously in the sense that you can advocate all you want in regards to how wonderful IR is, the quality of medicine that we practice, how efficient it is, but until you can actually prove that to them by essentially contributing to their campaigns, you basically have to do that in order to put your money where your mouth is. Lastly, the reason that we contribute to these candidates through the SIRPAC is to build relationships. It's that simple. You see from this picture here, there's a representative from Kentucky who a lot of our leadership have become very close to. On your left is former SIR President Marshall Hicks. To your right is one of the committee chairs, Joey Steele. They've met with Representative Guthrie on a number of occasions, and through that have built a relationship to the extent that we've been able to pass some legislation and bounce some ideas back to the representative. And that's essentially what we're trying to do. Is it's not just to build relationships, with myself and with some of the other lobbyists, but with you all as members and as leaders of SIR. Next slide, please. So that basically kind of entails what SIRPAC is and what it does. But of course, there's follow-up, and that is advocacy. So SIRPAC is essentially the key that gets us in the door, but of course, you got to take it a step further and actually advocate successfully on behalf of the society. So we do this, of course, on an in-house level, but again, we rely on our volunteers. Ali has done it, Paul has done it, and I know some other folks on the call have probably been to Capitol Hill as well. So it's really important that you stay engaged. And just to give you an idea about the advocacy, a little story. When I first started lobbying for SIR about 9 years ago, we had a meeting with members of the Ways and Means Committee. And back then, there was a bill called the Champ Act, and what the Champ Act did was it essentially diverted the SGR into 6 different silos as opposed to one, big silo as it is now or it was last year. And as part of those silos, they essentially divided payment into different groups. IR was supposed to be in imaging, while for the most part we wanted to be moved into surgical, because the majority of IR procedures are, of course, more surgical than they are just diagnostic. So we went in to speak to a couple of these folks, and when you have an image of Congress, you have an image of how policy gets done, how laws are made, you think that they might have a panel of experts, medical experts, physicians, scientists, that sort of thing, that kind of relay to the members of Congress how medicine should be practiced, how laws should be orchestrated, that sort of thing. But in reality, they don't have that. So their healthcare experts are a lot of times just fellows. So they're essentially interns that kind of give some input into how certain legislation should be enacted. Anyway, so we went in to speak to the Ways and Means Committee, and the fellow at the time was a retired physician. We wanted to basically advocate that IR should be in the surgical silo as opposed to the imaging silo, which would have represented a 41% cut as opposed to only a 9% cut in surgical. When we went to meet with this particular representative and fellow, we explained to them that IR is more akin to surgery than it is to diagnostic. And with the current SIR president sitting right there, the fellow literally laughed and said, "Why should I put IR in the surgical silo? Because the most complicated procedure you all perform is an angioplasty." So that just kind of gives you an idea of what you're dealing with in Congress, and why it's so important to advocate, because a lot of times, just to be perfectly honest with you, they have no clue. They have no idea what you do, and they have no idea how to implement some of those strategies and policies to cater to IR. On this list here are some examples of some of the things that we've been doing and what we've done in the past in regards to advocacy, in regards to how that SIRPAC money comes into play. I just mentioned the Champ Act 2007. In 2011, we helped pass a bill that addressed drug shortages. As you know, and even to this day, there's been a persistent problem when it comes to having a shortage of certain types of drugs. And so this particular bill essentially required drug companies to notify the FDA if they were potentially going to be in shortage of a particular drug. Another bill that we helped implement was a bill that kind of increased funding for medical research. In particular, this particular bill increased funding for UFE. We advocated to ensure individuals who practice imaging have the proper credentials. So this is essentially an appropriateness bill, where you make sure that physicians and then the folks that are actually certified to practice imaging as opposed to nurses, that sort of thing. Lastly, we advocated most recently to have IR recognized as its own primary specialty, and as you know, in 2012, IR was recognized as its primary specialty. One of the bills that we're working along with this is a bill regarding increased funding for Gme, which we can get into a little bit later. Next slide, please. Upcoming issues. Some of the things that we've been working on now are, as I just mentioned, the Gme Bill. So the way this works is that as it stands right now, obviously each particular institution or hospital is given a certain number of allocated Gme slots that are funded through the government. This particular bill would place an emphasis on newly created primary specialties and allow them to receive additional slots in order, for us to basically increase education and funding of IR. And of course, with the new residency program, that sort of thing, it's going to help out a lot, just in the sense that we're going to be able to give hospitals those extra slots so that they're not limited to the slots they already have in play now. So instead of having to cut another program, for example, even say diagnostic radiology, they have the ability to fund those extra IR slots. This bill has been in process for about a year and a half now, and actually the last group that attended the grassroots program, which we can get into later as well, was the first group to actively lobby for this particular bill. So as it stands now, we're somewhat of a holding pattern, just in the sense that we're just trying to figure out, whether or not they're going to address GME. But the ideal situation is that we eventually introduce this as a standalone IR bill, and if need be, we can incorporate that to a larger, broader GME bill. So we're looking at maybe sometime later this spring, if not summer, to determine whether or not they pick this up. But of course, it being an election year, things kind of get iffy, and if nothing gets enacted by the summer, they usually kind of wait until after the election to get started. I mentioned earlier drug shortages. That's another big issue, and that's something that we're continuing to push for, because one of the problems with that new legislation that went into place a couple of years ago that I mentioned is that even though the law requires a lot of these drug companies to give notice of potential drug shortages, there's really no enforcement mechanism. So a drug company can essentially just ignore this law and without any real repercussions. There's no monetary penalties, and there are no civil penalties. So that's something that we're continuing to work on. Lastly, and probably most importantly to a lot of you folks, is MACRA. So of course MACRA replaced the old SGR system, and the SGR, for those of you that don't know, was the old payment that basically dictated through Medicare how physicians got paid. The new system is essentially going to be called MIPS, which is an acronym for Merit-Based Incentive Payment System. The way that works is, as opposed to the current fee-for-service system that you have now, where essentially you perform a procedure, there's a code, you get paid according to what that code says. This new system is going to essentially give you a composite score from 0 to 100, 100 being the highest, and it's going to basically compare you to your peers. So if you score within the median, you're going to see essentially a flat payment. If you score above that median, you'll see an increase in payment, and then alternatively, if you score below that, you're going to see a reduction in payment. So in other words, you're going to have to prove that what you're performing has quality and is efficient. So it's somewhat controversial, because although the former SCR system was something that a lot of people wanted to reform, there's some that argue that this system is the worst, in the sense that you could potentially be penalized based on how you perform, and even though you may think that you perform the procedure well and there was good outcomes, if you fall below the median based on the national average, you're going to get a reduction in payment. I mean, that payment is going to start off at a potential 3 to 5% reduction, but it can go as high as 9% in the outgoing years. Another part of the payment system that they're looking at through MACRA is something called the alternative payment models. And so what that is essentially what it sounds like. It's something that's not MIPS. And the way that works is that they're going to encourage providers to come up with different payment models in order to be reimbursed. So what will occur is essentially you're going to, as a physician, you're going to either choose to report your payments through MIPS or choose to report through the APM. And they both kind of vary in regards to how much you get paid and how much you can save, that sort of thing. Next slide, please. So what can you do to get involved? There's a number of things. On the advocacy level, you can check the SIR website. We're actually in the middle of a website renewal, I guess. And we're constructing a new website, which I think is going to be done by the third quarter of this year. You can check IR quarterly articles. I know that Paul Redolo and I think Ali is working on an article right now, and you'll be getting into some of these issues that we're discussing today. You can encourage others to get involved. And of course, you can get involved in advocacy yourself. I've said this before, and I really believe this. To get involved in advocacy is something that you really should strive to do, because if you don't speak for yourself, others will speak for you, and that includes your counterparts in vascular surgery, cardiology, even diagnostic radiology. To be perfectly honest with you, one of the common misconceptions is that we're all under the general house of radiology. But in truth, a lot of times our issues are completely different, and while we support each other, they're not necessarily the same. So just keep that in mind when when you and your colleagues give a contribution to the SIR-PAC, which is fine. I mean, it's going to help you as a radiologist, but it's not going to necessarily help you as an interventional radiologist.
Doug,
another way to get involved is.
Wanted to add one thing. I think we have a couple of questions here, if you don't mind. It's from Dr. Rajat Chand. Basically, he's asking what is some current legislation? Who are the candidates, lobbyists that are working against the IR agenda advocacy, and how do we stay knowledgeable about the pertinent, up-to-date concerns agenda? I think you might have gone over some of that stuff. I just wanted to address these.
What are the current? What current legislation are we following? Is that the question?
I think so. And then yes.
Yeah, So the big one, of course, that we're following is MACRA, and that's gonna take up the majority of our time, aside from the Gme Bill, and that's important because MACRA gets rolled out in 2019. So for this year and the next couple of years, you're still gonna follow the old fee-for-service system, but starting in 2019, that's basically going to be eradicated, and we're going to start with a completely new payment system. And so that right now is probably the top piece of legislation that we're following, and what we're trying to do is get our members ready for that. So essentially, MACRA implementation is going to be the top priority over the next couple months, if not years. And in regards to which members are involved in that, again, it's just the key members from the jurisdictions that I mentioned earlier, Ways and Means, Energy and Commerce, and Senate Finance, and Senate Health. So it varies depending on the member, but essentially any member of Congress that resides within those 4 healthcare committees is someone that we're going to target and someone that we're going to lobby.
Okay, and regarding the next question is how do we stay knowledgeable about the pertinent, up-to-date concerns agenda? Would you say that the SIRPAC website would be the best source, the news alerts on the right side, or?
The SIRPAC website, there's also a monthly publication that we put out called the Washington Interventionist Report, which is fairly involved, and that kind of gets into the weeds of some of the things that you might not see on the general website. We're going to probably try to do more webinars, just general webinars in regards to some of the issues that we've been following, some of the things that you should be looking out for. I know at some point we're going to put together a MACRA webinar just to give folks an idea of what to expect and how to go about preparing for that new law that's basically taking place in 2019.
Sounds good.
And then the other thing, of course, is if you're looking on the slide here, you can apply to join the Government Affairs Committee. So the Government Affairs Committee essentially is tasked with creating and implementing healthcare policy for the society, and that can range from anything from quality measure guidelines to appropriate guidelines, that sort of thing. And I'm obviously a little biased here, but I think that I honestly think that outside of the Economics Committee, this is probably one of the more important committees in the society, just in the sense that you're dealing with real life issues, scope of practice, payment, that sort of thing. And then lastly, and I'm going to throw it to you, Ali, for a little bit here, is as a trainee, you can get involved in the Grassroots Leadership Program. So next slide, please.
So yeah, as Doug was mentioning, I'm not sure if Paul has audio here. Paul is the former chair of the RFS Advocacy Committee. He's right. This is, let me see if I can point here. This is Paul, and that's me. We're kind of on the left side of the picture. The Grassroots Leadership Program, I thought it was a very, very interesting and successful program for trainees to be involved and first just become familiar with the with SIRPAC and the legislation and just basically what we just talked about in the last 20 minutes, and also have kind of a hands-on kind of presence within the House or the buildings of the Senate with different appointments that were indigenous to where the trainee was from. Like, for instance, I was able to meet with most of the basically congressmen from Tennessee, and there were other people from different states: Ohio, Florida, Texas, Arkansas, Vermont. So, and they basically had appointments set by Doug and I guess SIRPAC for us to go and meet with these representatives and just talk IR, talk about the Gme Bill, talk about the IR residency, discuss what IR is. I don't know if Paul can chime in here, but I know that Paul, for instance, had a very good explanation of what IR is. For instance, he would go up to a congressman and say, okay, we make a small incision about this big, and it would maybe make a little mark on a piece of paper and say we do everything through there. And that was just the introduction. And then it was like, oh, what kind of things do you do? And then we would talk about different catheters and different procedures, for instance, UFEs and kyphos and chemoembos and even access procedures, anything that they were interested in hearing about. And we try to cater our explanations to their interests, maybe even ask them about what their experiences have been with interventional radiology. I know that some congressmen knew about it, some knew a little bit, some didn't know at all. So we were able to really kind of tailor our explanations and be able to walk out of those buildings feeling fulfilled with what the message that we conveyed. We wouldn't get too specific, but it would really just kind of give SIR a kind of a presence within the congressman's office and be able to talk to the staffers or even themselves at some point, and kind of resolve any explanation that they needed, and kind of differentiate between diagnostic radiology, interventional radiology, and also at the end tie it back together and just let them know that we do use imaging to do these procedures, but we don't just do imaging. And all in all, for a common goal for them to understand what IR is and be able to essentially support the legislation, many to come in the future, as Paul was explaining, as Doug was explaining, that will affect us. And I don't know if that covers it, Doug. Did you want me to talk about anything else?
Yeah, if you can maybe go the next couple slides, I just want to.
Oh yeah, sure, absolutely. We have
summarize what that program's about.
Right. So basically, this was the setting. We would walk in, have an appointment with a staffer or the congressman, and just talk about what we talked about, from simple explanations to specific procedures. And basically, we wanted them to we wanted the staffer or the congressman themselves to be aware of our Gme Bill that will support our IR residency spots. And Doug, I know you touched on that. Did you want to add anything else to the explanation of Gme Bill at this point, or?
No, we basically covered it. It's essentially a ways to increase funding for IR residency slots in accordance with a new residency program. But just to give you a quick synopsis of the program itself, as a graduate or as an attendee of the grassroots leadership program, what we're going to basically be looking for from you all is to be grassroots regional directors, and essentially what that's going to entail is you to essentially be tasked with mobilizing a certain region from basically where you practice and where you train, and to help mobilize your colleagues, your attendings, the other trainees to get involved when it comes to a certain action alert. So an example, of course, would be once we hopefully get a bill number, it introduces as an actual legislative bill, you would kind of reach out to folks and encourage them to call their members of Congress, write that sort of thing. We, of course, would give you the the mechanisms today able to do that, but we want you to get involved. We want you to be leaders. Alternatively, if you want to switch over to the next slide, Ali. One of the other things that we want you to get involved with is to become advocates for IR in your region. So we do things like site visits, which Ali, you might want to get into. But we ask that you host a member of Congress, have them come to your hospital, talk to them about IR. And again, that helps us do a lot of things like build relationships, educate members of Congress, that sort of thing. If it's not a site visit, we sometimes will ask you to attend a fundraiser that occurs in your district. So, of course, fundraisers, as you can guess, typically occur in D.C., but during recess and on weekends, the members go home to their district, to their constituents, and as a constituent, as a member and a regional director of the grassroots program, we would ask that you represent the SIR in that capacity as well. So I didn't know if you wanted to share your experience about that site visit?
So yeah, this is something that, as Doug was mentioning, I thought it was very impactful and important, and our trainees can, I wouldn't say super easily, but it's definitely doable to be able to ask a congressman to come visit your site and basically show them kind of firsthand what exactly IR is. And in this case, we were able to, with obviously the hospital's cooperation and approval, we were able to ask Congressman Marshall Blackburn from Tennessee to come and visit one of our hospitals. And basically, when she walked in, there was a kyphoplasty going on, so she was able to witness that briefly. And then the picture on the right, my attendings, Dr. Buchanan and Dr. Shelton, they're going over some imaging, which is important for her to understand that we are basically using imaging for these procedures, and then some anatomy, and then kind of understanding what's happening with the kyphoplasty, for instance, and the benefits and what type of patients and how it could be outpatient, and the rate of complications, which are obviously very much lower than open surgery, and if done correctly, obviously. And basically, that was one of the explanations. Then Dr. Shelton, once standing up, he was able to demonstrate a case of UFE on the computer, kind of comparing the before and after MRIs and kind of explaining exactly how it's done, why it's done, and what patient population it could serve. And then we were able to take her inside to the interventional suite and show her what a catheter is, kind of like the basics of like, what Paul and I would talk about to the congressman in their office. We have a tiny basically incision, a catheter goes in. We were just able to kind of show her what that is, and she was able to palpate it, feel it, and kind of ask questions about that. And then she also, what she brought up actually, and I spoke with Doug about this as well, was that she was very concerned. Right now, one of the hot topics on the Hill is pain management and opioid addiction. And that's something actually that my attendings who are part of a practice actually manage on a weekly basis, patients with chronic pain. And currently, one of my attendings, Dr. Angel's on the call. Dr. Angel, are you able to hear us?
I can hear you. Can you hear me fine?
I can, thanks. If you don't mind explaining what we explained to Congressman Blackburn with regards to pain management with your practice.
Sure. So to give a little background, I unfortunately was not there at the hospital that day. I was actually at the RUC meeting with the SIR Economics Committee talking about new CPT codes. So I sadly had to miss that. And also, it's unfortunate that she showed up about a week before that hospital got a bunch of new software that would have produced very pretty pictures, the sort of IMO guides and 3D reconstructions that we are starting to use more and more of now, which is sort of always a crowd pleaser. But I think pain management, it's something I did an elective of in fellowship without getting, I guess, too sidetracked. And I think you're going to see a growing role in interventional radiology, not just from the sort of primary role of pain management and how all the different services that we can offer, but in addition, it's sort of a referral guide. If you get into pain management, it's something that I've sort of gotten into in my first year out in practice, along with Dr. Buchner, the guy with the white coat on in those pictures. But you'll see it as a referral base for other practices. It goes very well with oncology. A lot of the procedures sort of overlap with the palliative care that we do with some of the oncology procedures, and it refers to other stuff too. Some of the people that you refer to for sciatica or chronic leg pain are actually vasculopaths that end up with PAD and can produce other interventions. So I think he approached that from a standpoint of what the opioid addiction and how we can take a more regulated approach. But anyways, yeah.
Exactly. Thanks so much for the explanation. Yeah, so those are some of the things, and I wanted Dr. Angel to share because he actually is intervening with these patients. And, but she was very happy to hear that, and that's something that I wouldn't say it was a curveball, but I didn't think she was going to kind of bring that up. But luckily, the practice that oversees my residency doing a lot of these procedures, we were able to say, listen, IRs can do this. We can manage chronic pain, and just like Dr. Angel was mentioning. So these are some of the things that residents can do with, like myself, with their attendings, and it's not a very difficult preparation. Usually the hospital is on board. Usually attendings are on board, and they're happy to speak. And she spent about, she said originally in her email she was saying about 25 minutes, but she ended up spending about almost an hour with us. And I thought it was a very successful visit for her to really understand what IR is. And then once we do this, for instance, when we go back and do the grassroots leadership program, once we pop in her office, she knows exactly what interventional radiology is, or at least more than the congressman next door. And she can be a leader for us for the issues that we want to push through Congress. So I'm not sure if Paul wanted to add anything, because I know he had a site visit as well. Paul, are you able to speak?
Yeah.
Okay, great. Did you want to share anything about that?
Yeah, so a couple things. So as far as site visits, I had one at Maine Medical Center when I was in residency, and I tried to arrange it. The first one I just kind of lucked into. The second one was a lot more difficult to try and arrange. So I would suggest, if you're going to set up a site visit, talk to your department first. Make sure you get everything in line with your department, then go to the hospital, because usually at some point you have to involve the overall hospital. And when you do that, they're going to try and scoop it and try and take them to the areas that they want to be seen, because they're not looking out for IR, they're looking out for themselves and get more money for, their ICUs or neurosurge, whatever. So make sure you have everything lined up. And it's great when you do the grassroots, because you can meet these people and you can kind of start a relationship with their staff, with them through an email. And so they already have an established relationship, and that goes a long way to help you kind of control how the site visit goes. For my site visit, the story I like to tell, so my guy came in and he actually, he watched me do a neph tube exchange, and he thought it was the most amazing thing in the world. He had never seen anything like that. He thought it was the most complicated procedure, and it was like a simple thing. I did it on my own. Attending was sitting in the control room, and we come out, and the guy was just totally blown away by what we were able to do. And then he had some extra time, and so I made him discharge my DVT lysis patient, which he got a huge kick out of. He got to go meet them and talk to them and learn. They, explained the role that IR played in their child's care, and how happy they were, and the relationship that we had established. And as we were leaving the hospital, we went past the hospital CEO, who stopped over, said hi to the representative, and said, where were you today? Where did you go? And he's like, oh, I was in radiology. And the CEO was just aghast that he had been sitting in radiology, and immediately he says, oh, I'm so sorry. I apologize. We should have gotten you somewhere where there are patients. That's our mistake, blah, blah, blah. The guy immediately chimes in and goes, no, I saw tons of patients. These guys have great patient care, and goes on to brag about the DVT experience that he had and the obvious relationship that we had formed with our patients in such a short amount of time. And the CEO was blown away. And that's a huge thing for a representative to walk away with, to have that picture of interventional radiology. And that's really what sets us apart from diagnostic radiology and RADPAC. And when you go and you meet with congressmen and senators, that's a point. The patient care is a point that you really want to get across to those people. You want them to understand that we are not just sitting in a room reading films. Because the second you go try to lobby and advocate for your profession, and you say, we're not involved in patient care, eyes glaze over, people stop listening because they don't really care. Because they want to what they're really focused on right now are people who are affecting patients, because A, it's in the news, and B, they're voters. So if you go in there and you say, I don't deal with patients, I just look at films, you are immediately on the cutting block. But if you go in there and show that you are affecting patients, making their lives better, making them more comfortable, curing them, treating them, suddenly they get very, very interested in what it is you're doing. And when you explain to them that someone getting a AAA repaired endovascularly versus surgically is going to be going to work a lot earlier than someone who has open surgery, or someone who gets a UFE instead of a hysterectomy is going to have less time in rehab, less time out of work, which means less cost to the system. Suddenly their ears perk up and they get very, very interested, because that's what the government's focusing on right now, is how they can cut costs, how they can decrease the hit to the system. And it's not just the pricing of the case itself, because in a lot of studies it's shown that IR cases up front cost more, but the long term, when you look at all the extra stuff that goes into it that isn't really talked about, like the time missed from work, the time on disability, That's all cost to the system. And so when you quantify that for them and show them, look, these people are going back to work in a week as opposed to being out for 6 weeks, suddenly they get very interested. And that's very important. It's a great way for us to distinguish ourselves from our diagnostic colleagues.
I agree completely. Go ahead, sorry. I was going to chime in and mention something about, you said about cost, and that's something that Congressman Blackburn was very concerned with, and she obviously throws the term around, the term cost-effective around, and basically, kind of follow up on Paul, we were explaining to her how most of the procedures for interventional radiology are outpatient, so that the hospital stay cost is really non-existent. So that's another thing to throw in the mix. Go ahead, Paul, sorry.
So as far as, you guys were talking about pain, I have a very keen interest in pain, and I think that is as was said before, that's something that I think IR is going to be able to branch into and really kind of take control of. But one of the things that you can, to give you a specific example, sacroplasty. Where I did my training, it was incredibly difficult to get paid for sacroplasty, regardless of the fact that it worked, that there were studies, very good studies, that showed that it's effective, that it's better than just giving somebody opioids for months and letting them just deal with the pain. It was still incredibly hard to get paid for it. So if you talk to your congressman and you explain to them the situation, or better yet, you show them someone who has a sacroplasty, you show them before and after and their pains, how the pain goes away and how happy they are, and they're not sitting on opioids, they don't have that risk of getting, A, they're not bedridden, they're not taking up extra services and resources, but B, they're also at less risk for getting hooked on opioids. Huge win. And then you can actually have them go back to their committees and say, hey, wait a minute, this should be getting reimbursed. This is baloney that we're not reimbursing this fantastic procedure. And that's going to be, as we push the envelope further and further and invent new procedures, those are going to get classified as experimental. And those things are going to be either not paid or paid a lot less. And so, again, that's something that we have to advocate for ourselves. And the way to do that is to have a voice at the table, and that's your PAC. And if you don't have a PAC, it's like you're waiting to get punched in the face. And when you get punched in the face, if you don't have money, there's nothing you can do about it. And that's exactly where SIRPAC comes in. That's how we protect ourselves. It's how we advocate for ourselves and protect our specialty. And as Ali can tell you, both I and him did the Rutherford Levante Fellowship, which is done through ACR, a program, and I would encourage everybody to apply for it. You get to go to these. You can see what a $3 million PAC, which is what RADPAC is, what they're involved in. And you can see, you go to these meetings with multiple specialties, and you hear them all sit and talk and advocate for themselves. And that's something that IR needs to be at the table. As we become our own specialty and become our own, develop our own identity, we need to be at the table, and that means we have to support our PAC. And when you sit around the table, if you're not there, I guarantee you the cardiovascular lobbyists, the vascular surgery advocacy groups, they're not going to be pushing for IR to get paid. They're not going to be pushing for IR to be involved or anything. They're not advocating for us. They're advocating for themselves. So if we don't support ourselves and we don't give ourselves the weapons and the opportunity, then we're going to be left out in the cold. And that's the sad, hard truth.
Totally agree with Paul. That was a very good fellowship, Rutherford Levante. It was a very good fellowship to be in for the week to understand how they do their work and actually borrow some of those ideas and apply it for SIRPAC and even do a better job with SIRPAC. So that's essentially what Paul was mentioning. We have about 10 minutes remaining. I was going to say, Doug, if you wanted to explain a couple more slides, and then we have a question here as well that I wanted to answer here with Dr. Chan. How easy are appointments made with policymakers? Is a liaison like Doug necessary to set that up? I would say yes. Doug will set it up, and Doug, please chime in if you need to. But Doug was definitely a key figure in setting this up with Congressman Blackburn, being able to do the DC appointment side, and then I was able to be put in touch with her staffers and coordinate from there. So, Doug, is there anything else you want to add to the policymakers visit?
No, you know what? It honestly depends on the representative, themselves. Some are easier to work with than others. So, in this particular instance, Congressman Blackburn, and by the way, that's not a typo. She's one of two members of Congress that's female, refers to be known as congressman. But anyways, it depends on the member. Blackburn, for example, is really good about trying to engage with the constituents, and ironically, I don't believe that your hospital is even in her district. but it was close enough that she wanted to visit. So the same can be said for other representatives, because you have to remember that although your institution might not necessarily be in their district, chances are that their patients will be at your hospital. So it varies. Sometimes it's something that's really easily done. Sometimes it takes a while. But at the end of the day, they do want to meet with their constituents. So whether they get to you within a few weeks or a few months is something that will eventually happen. Again, it just depends on who it is regarding whether, how easy it is to do that. But we can certainly reach out from our end, and then again, I think Paul mentioned that, and Ali mentioned that you just kind of have to coordinate that with your hospitals to try to make that work. I know we run into some instances in the past where it became kind of political, and they didn't want a certain member there for various reasons. But for the most part, it's doable. You just have to be patient with it. And I guess for the last couple of minutes, barring any more questions, I just wanted to emphasize some of the points that Paul kind of alluded to earlier, is just to give you a general idea of where we are in regards to numbers. SIR has roughly 5,800 members, and the average IR contribution is about $250 per year. In 2015, we collected about $42,000, yet only 6% of our membership actually contributed. And I think ACR is hovering around 12 to 15%, so that they have about, obviously twice the number of contributors that we do. Go to the next slide, please. Again, just to give you a general sense of where SIR stands, if you look at some of our competitors or colleagues, if you want to call them, ACR, Paul mentioned they raise roughly $3 million per cycle, and the cycle is basically every 2 years. So this particular cycle constituted 2012 to 2014. The cardiologists raised about $900,000, and the vascular surgeons raised about $206,000. And just to note, I think that their membership is actually smaller than that of SIR, so we have some work to do. We collected about $102,000 in the last cycle. It's easier for me to easier said than done, but in regards to how much you can give, I think it's one of the things you have to kind of take into account what the potential consequence of not giving is. As the slide here indicates, if each member gave $250 per year, which I'm not expecting that to happen, but we would have obviously a PAC that would exceed even that of the ACR, probably even that of the anesthesiologist. If each member gave only $50, we'd have almost $600,000, which is obviously 6 times what we normally have. And even more realistically, if just a third of our membership gave $100, we would bring in roughly $400,000 per cycle. And I know Paul put together what he called the 400 campaign, and the goal was to essentially raise $400,000 per cycle. And I think it's doable. If you really look at the ins and outs of why you should give, we mentioned that earlier. I think that's something that you should really look into. Just to give you a little side story, one of my colleagues and a long-time lobbyist, former Hill staffer, told me that when he was working on the Hill, when you called in to get a meeting set up, next to the reception is the list, and on that list is a list of donors. So you can kind of see where I'm going with this. It's one of those things where we're not doing this out of boredom. We're not doing this for the sake of having something to do. These dollars actually amount to something. So again, just try to get involved. SIRPAC is the oil that gets the advocacy engine running, and without that, we can still do our job. It just makes it a lot easier to do it when you have some money to back that.
Can I just add one thing real quick?
Sure.
So just to illustrate how important it is to give, or what a great investment it is to really give to SIRPAC, is that so if you give $100 a year, or I'll be honest, I give 50 as a fellow, I give $50 a month. You're investing in protecting your future. And to bring that point home, I was at a meeting with Congressman Tim Murphy, and orthopedics was there, radiology was there, dentistry was there, family medicine, OB-GYN, neurology, psychiatry. And Congressman Murphy said, everybody go around and tell me one thing that you want me to hear, that you want me to work on for you. And the first guy that spoke up was the representative from neurology. And he immediately started railing on the fact that when the ACA was put into place, they designated certain specialties like family medicine, internal medicine, and OB-GYN as primary care specialties. And as a result, they got a 10% bonus on certain codes. And his argument is that neurologists and psychiatrists function as primary care for a lot of their patients. And they do the exact same, they code the exact same codes, they submit the exact same codes as family medicine, internal medicine, and OB-GYN. But even though they're doing the same amount of work, and even though they're coding the exact same codes, they're not seeing that 10% bonus on their reimbursement. They're seeing 10% less for the same amount of work. It is not too hard to extrapolate to the future. Cardiology and vascular surgery doing the exact same thing at the table with us not there, saying interventional radiology doesn't deal with patients, they don't follow patients, they don't have patient care, they're just technicians, they don't deserve a 10% bonus, or they don't deserve any extra, and that cardiology and vascular surgery should be getting paid more per code than the interventional radiologist. So that is where your investment is to protect yourself from a situation like that the neurologist and the psychiatrist are currently in. That's it. Thanks.
Thank you, Doug. Paul, sorry. Keep calling Doug, Paul, Doug, mixing it up. Doug, is there anything else you wanted to add for the credits and the closing before we go to questions?
Just to wrap it up, at the SIR annual meeting in Vancouver, we're having a town hall meeting on April 5th, and that same day we're going to have a reception for SIRPAC donors at 6 p.m. in the convention center as well. So if you're there, stop by, say hi, come with questions, feel free to participate.
And I think just to add to the advocacy and the advocacy town hall and the SIRPAC reception, myself, Paul, and Doug have put a lot of work into this. I think it's going to be a great event. So please come address questions, listen, be involved in the discussion, which is going to be obviously a lot more live than a webinar. So now we have about 5 minutes left. Is there any questions? I think if you submit your questions, I can able to read them out, and myself, Doug, and Paul will try to answer them. So far, we've had 3 questions. Anyone? No? Okay.
Yeah, just to wrap this up, some of you may have known Pete Lauer. He was our late SIR executive director, and he used to always say that the SIR was the member's sandbox. So remember, this is your sandbox. Help protect it. Fight for it.
Right, and just to kind of add to that, SIR is the only entity that advocates for IR, and SIR Advocacy and SIRPAC, they're 2 separate entities, but they work congruently to complement each other, and it's very important for SIRPAC to help us build relationships with lawmakers, like I said, to shape the future of medicine. So the donations you're giving to SIRPAC or we're asking and we're trying to get stronger are not going in anybody's specific pocket. They're helping IR, like Paul and Doug both mentioned, helping us expand and become a bigger figure at the tables that all of us have sat at with the congressman, and be able to have a stronger voice and essentially shape the future of IR. So those are the things I wanted to add as well, because a lot of members sometimes wonder, well, where's my money going? And it's just very important to make sure we close with that. Anything else, Doug or Paul?
That's it for me.
All right. Well, thank you, Doug, for joining us. Thanks everyone else as well for being on this webinar. I'm planning on posting this on the RFS YouTube page. So if you want to watch it again and listen to it, and or hopefully send it to your colleagues and your attendings and anyone that wants to contribute to SIRPAC, basically, definitely do that. So it's going to be an easy link. It should be up by the end of the week. So with that, if there are no more questions, I will go ahead and close the meeting. Thank you so much again. Have a great night, everybody, and join us for the future SIRPAC webinars.
Thanks, guys.
Thank you.
Thanks, everyone.